Welcome to the Hospital Medicine Unplugged podcast. Today we are taking a deep dive into evidence-based transfusion practices, synthesizing the latest guidelines from major bodies like AABB, ACCP, and large Cochrane reviews. You know, blood transfusion is such a foundational intervention in hospital medicine. It's often life-saving.
Yeah.
But I think we sometimes forget just how frequently it's used and the profound risks it carries.
It's a massive scale intervention. It really is. And that's precisely why the evidence needs to be so rigorous. Just think about the numbers for a second. Approximately 25% of all patients in the ICU will get a transfusion.
A quarter of all patients. That's huge.
It is. And if you look nationally in the U.S., back in 2021 alone, we used over 1.7 million RBC units. And that's just in critical care settings.
Yeah.
So when an intervention is that frequent, the slightest error in practice or even the slightest unnecessary exposure, it just leads to major patient safety concerns.
And that scale is exactly what drove the philosophical revolution we've seen over the last couple of decades. We're now firmly planted in this restrictive transfusion paradigm. We've had to sort of dismantle decades of clinical tradition that often relied on the idea that more blood is always better.
Exactly. And it's important to stress that the shift is not based on cost saving, though it does save costs. It's driven entirely by high-quality, randomized controlled trials. And these trials prove that, for most people, lower hemoglobin thresholds are not just adequate, but actually safer.
So when we talk about these strategies, let's be really clear on the definitions for anyone who might be newer to this.
Good idea. So the restrictive strategy, that's what we're aiming for now. It means intervening only when the hemoglobin threshold is typically less than 7 to 8 grams per deciliter.
And the older liberal strategy.
That's the one we're trying to abandon. That meant intervention when the hemoglobin was less than 9 or sometimes even 10 grams per deciliter, a much lower bar for transfusion.
I think it's crucial to remind ourselves why we're so cautious about giving blood in the first place. I mean, it's not like infusing saline. What are the major adverse events we're trying to reduce every time we avoid a unit?
The list is pretty significant. At the top of the list today is transfusion-associated circulatory overload, or TACO.
TACO.
This is now the most common serious reaction we encounter. Then there's transfusion-related acute lung injury, TRALI, which is often much harder to manage. And, beyond those immediate acute issues, we have the subtler but still critical immunomodulating effects of blood products.
Immunomodulation. Can you expand on that a bit?
Sure. It means the transfusion can sort of dampen or alter the patient's immune response. And this may increase a patient's risk of developing a nosocomial infection or even prolong their hospital stay. So minimizing exposure directly addresses these highly undesirable risks.
So our mission today is really to distill those core guidelines for RBCs, for platelets, and for plasma. But the real value for our listeners, who are all practicing hospitalists, is understanding the nuance. Where does the hard number break down, and where must clinical judgment supersede the standard threshold?
That is the core challenge. Absolutely. We need to internalize the guidelines, but ultimately, we are treating a patient, not a lab result.
Okay, let's start at the beginning then with the core of the evidence. Red blood cell transfusion. The entire edifice of restrictive transfusion really rests on one landmark trial, the Transfusion Requirements in Critical Care Trial, or TRICC.
TRICC, published back in 1999, and it was absolutely groundbreaking. It took critically ill patients and randomized them to one of two arms, a restrictive strategy.
Transfuse if hemoglobin fell below 7 grams per deciliter.
Versus a liberal strategy. Transfuse if it fell below 10 grams per deciliter.
And the finding was, well, it was startling at the time.
It really was. There was absolutely no difference in 30-day mortality between the two groups. This just fundamentally changed the goal of transfusion. It shifted from just correcting a number to ensuring sufficient tissue oxygen delivery, regardless of what that number was.
And that finding wasn't just a one-off, was it?
Yeah.
It's been validated time and time again, leading to the ironclad consensus we have today.
Absolutely. The most robust confirmation comes from a massive Cochrane review. It included over 61 randomized controlled trials and more than 27,000 adult participants. Just a huge body of evidence.
What did that meta-analysis show?
It provided high-quality evidence that the restrictive strategy was overwhelmingly safe. It reduced the risk of a patient receiving at least one RBC transfusion by a staggering 42%.
42%? That's incredible.
It is. And crucially, this massive reduction in resource use and patient exposure did not increase the risk of mortality, myocardial infarction, stroke, thromboembolism, or infection.
So there was no downside, just a huge reduction in transfusions?
Exactly. No downside in those major outcomes.
That is the data that should be guiding every single order we place. So moving from that evidence base to current clinical practice, what are the definitive current standard thresholds from bodies like AAB?
The 2023 AAB International Guidelines really lay out the contemporary standard. For the general hospitalized adult population, so your typical patient who is hemodynamically stable, the strong recommendation is to consider transfusion only when the hemoglobin concentration is below 7 grams per deciliter.
So 7 is the magic number.
7 is the number, and that's a strong recommendation backed by moderate certainty evidence. It's the baseline for most of our patients.
Now, we know there are specific cohorts where that risk-benefit analysis shifts a bit, particularly for surgical patients or maybe those with pre-existing heart disease or CAD.
Correct. We do see slightly higher but still restrictive thresholds in these specific areas. For instance, patients undergoing cardiac surgery have a slightly higher threshold, often around 7.5 grams per deciliter.
And for orthopedic surgery or patients with known CAD.
For those patients undergoing orthopedic surgery or with established CAD, the threshold is typically 8 grams per deciliter. The rationale here is really to err on the side of caution. You want to maximize oxygen delivery to vulnerable organs like the myocardium, which is paramount in those settings.
Okay, so despite this clear, high-certainty evidence for the 7 gram per deciliter threshold, the critique mentioned that clinical practice still lags. Why is that? Why are clinicians still pulling the trigger when the hemoglobin is 8 or 9?
This is a huge problem. It's a mix of cognitive dissonance and institutional inertia. International data consistently shows the mean hemoglobin level before transfusion is often 7.7 or even higher.
So still well above that 7 threshold.
Well above it. Part of it is the lingering effect of historical teaching, the old 10-30 rule.
The idea that you needed a hemoglobin of 10 and a hematocrit of 30?
Exactly. That was a magic number for decades.
Yeah.
And it's just very hard to undo that kind of ingrained habit.
It really is.
And another element is risk aversion. Think about it. If a patient experiences an adverse event from anemia, say, they have some chest pain, a physician who withheld blood will often feel a sense of failure.
Right, a sin of omission.
Precisely. But if a patient develops TACO from an unnecessary transfusion, the link feels less immediate, somehow less culpable. It's a sin of commission.
So we need robust systems in place to overcome that cognitive bias.
We do. Things like the single unit default we can talk about later.
That brings us perfectly to the importance of the clinical context. Because the hemoglobin number, it's a cheap, objective test, but it's utterly meaningless in isolation.
Absolutely. Good practice guidelines demand that transfusion decisions incorporate far more than just the concentration. We must be assessing for clear signs of inadequate oxygen delivery. Are they symptomatic?
Are they short of breath?
Are they experiencing dyspnea, extreme fatigue, lightheadedness, or critically, are they having chest pain that you think is cardiac in origin? That angina, that sign of myocardial ischemia that often dictates immediate transfusion, regardless of whether the hemoglobin is 7.1 or 7.9.
And beyond symptoms, we also need to be looking at the patient's ability to compensate hemodynamically.
Precisely. Is the patient hypotensive? Are they severely tachycardic?
And importantly, is that tachycardia or hypotension unresponsive to a reasonable fluid challenge?
Yes, that's a key point. We also need to factor in how fast the hemoglobin is declining and their overall intravascular volume status. If they are actively bleeding, that is a completely different conversation. But for the stable patient, symptoms are king.
And when we do cross that threshold and decide we have to intervene, the standard should be a precise titration, not a bulk order of 2 units.
That is the absolute foundation of patient blood management. The AABB Choosing Wisely guidelines strongly emphasize that the single-unit RBC transfusion, followed by a careful clinical reassessment, should be the standard of care.
For any hemodynamically stable patient who isn't actively hemorrhaging.
Exactly. You give 1 unit, you recheck their symptoms, you recheck their hemodynamics, and then you decide if a second unit is truly warranted. This practice alone eliminates a massive amount of unnecessary exposure.
Okay, let's move now to the truly critical exceptions. The specific populations where we must intentionally ignore that restrictive standard because the pathophysiology demands a higher target. The first major deviation is in neurocritical care.
This is one of the most interesting and, frankly, conflicting areas in critical care medicine. For critically ill patients suffering from an acute brain injury, whether that's a traumatic brain injury, a subarachnoid hemorrhage, or a severe stroke, a liberal transfusion strategy actually appears to be beneficial.
More blood is better for the brain.
It seems so. Studies are showing lower unfavorable neurological outcomes at 6 to 12 months when patients are transfused to a higher target.
So why is that? Why does the brain seem to need more hemoglobin than, say, the gut or the liver in that acute setting?
The primary mechanism is maximizing oxygen delivery to the injured brain tissue, the penumbra. When a patient has an acute brain injury, they often suffer from impaired cerebral autoregulation. Their cerebral perfusion pressure, or CPP, becomes critically dependent on their mean arterial pressure.
So any drop in blood pressure directly reduces brain perfusion.
Exactly. And if they're also anemic, that combination can lead to secondary brain injury just due to ischemia. So by targeting a higher hemoglobin level, we increase the oxygen carrying capacity of the blood flowing through that already compromised circulation, which helps to prevent that damaging cerebral hypoxia.
That makes the shift from a systemic restrictive policy to a neurospecific liberal policy much clearer. Okay. Now let's talk about another surprising deviation, GI bleeding. The evidence here seems completely counterintuitive.
It is remarkably counterintuitive, and this is where a deep dive into the physiology is really required. You might assume that with active gastrointestinal bleeding, or GIB, you should be aggressively transfusing to keep up.
Right, blood out, blood in.
That's the instinct. However, the evidence from randomized trials shows that 30-day mortality was actually lower with a restrictive transfusion strategy.
Lower mortality with less blood.
Mm-hmm.
What was the risk ratio?
The relative risk was 0.63, so a very significant reduction in mortality. Restrictive was safer.
So why does aggressive transfusion hurt a patient who is actively bleeding, especially if they have underlying variceal hemorrhage?
The dominant theory involves portal pressure. When you aggressively transfuse blood, you not only increase the intravascular volume acutely, but you also increase the viscosity of the blood.
Okay, so the blood gets thicker.
Right. And if the patient has portal hypertension, this increased volume and hyperviscosity raises the portal venous flow and pressure. You're essentially popping the clot that their body is trying to form, and that can lead to rebleeding.
So you're just creating a vicious cycle.
You are. The restrictive approach seems to maintain a more optimal balance, allowing for clot stability without cranking up the hydrostatic pressures in the splenic circulation that feeds those varices.
That's a critical insight for anyone on call managing variceal bleeds.
Now, you mentioned acute coronary syndromes, or ACS, as the area of highest uncertainty. Where does the data leave us there?
ACS is a clinical tightrope walk. There's no other way to put it. We have robust data showing that anemia exacerbates myocardial ischemia, which is obviously bad for the heart.
But we also know that transfusing carries risks like TACO and hyperviscosity, which are also detrimental to a compromised heart.
Exactly. You're caught between a rock and a hard place. And the problem is the evidence base is just tiny. We're relying on 2 small pilot trials with a combined total of only 154 patients.
That is barely enough to establish proof of concept, let alone guide millions of clinical decisions every year.
It's not. And because the data is so limited, the guidelines are all over the map. They range from the general 7 grams per deciliter all the way up to 10 grams per deciliter for some high-risk ACS patients.
So what does that mean in practice for the hospitalist at the bedside? In practice, this forces clinicians into a highly individualized risk assessment. If the patient has active ischemia, ongoing chest pain, dynamic ST changes, you transfuse, even if their hemoglobin is 8.5.
But if they're stable?
If they are stable post-event, you might hold off until 7 like you would for any other patient with CAD. It's all about the clinical picture.
Finally, before we transition, let's just touch on pediatrics. Are the adult restrictive rules portable to children?
For critically ill children who are otherwise stable, so they don't have a preexisting hemoglobinopathy, cyanotic heart conditions, or severe hypoxemia, the general restrictive threshold of less than 7 grams per deciliter is applied, similar to adults.
But in kids with congenital heart disease, I imagine the nuance is extreme.
It is. The physiology of, say, single ventricle palliation requires a completely different approach. These children require highly tailored and often much higher thresholds. For example, a child undergoing a biventricular repair might still adhere to the 7 grams per deciliter threshold.
But not the single ventricle kids.
No. Those children who have to rely on a highly specific balance of systemic and pulmonary flow may require a significantly higher threshold, sometimes 9 grams per deciliter, just to ensure adequate systemic oxygenation.
That sets a very clear framework for RBC transfusion. So let's shift gears now to platelet transfusion. This intervention is much less frequent, right? It only makes up about 6% of ICU transfusions, But the rules feel much more procedural and count-dependent.
They are very precise, and the general trend is toward highly restrictive platelet use. You have to remember, platelets are inherently less efficient than RBCs at increasing tissue oxygenation. Their use is almost exclusively prophylactic or therapeutic for bleeding that's related to thrombocytopenia or platelet dysfunction.
Okay, so what's the standard prophylactic threshold for a typical, stable patient who isn't actively bleeding and has no high-risk comorbidities?
For that low-risk, non-bleeding, critically ill patient, the standard threshold is suggested if the platelet count falls below 10 times 10 to the power of 9 per liter.
So count to 10,000. That's very low.
It's very low, and it reflects that the risk of spontaneous bleeding is generally minimal above that level, provided the platelet count drop was slow and not precipitous.
And what if we know the patient has an underlying high risk of spontaneous hemorrhage, or they're in a specific hematologic situation?
In cases where there's an increased risk of spontaneous bleeding, the suggested threshold moves higher, usually to a range of 30 to 50 times 10 to the power of 9 per liter.
A count of 30 to 50,000.
Right. But this is still a conditional recommendation based on very low certainty evidence. It just recognizes the increased clinical jeopardy. We see this often in specific hematologic or oncologic patients. For example, those with hypoproliferative thrombocytopenia who are receiving chemotherapy or an allogeneic stem cell transplant.
I recall the guidelines for that chemo and stem cell transplant population are particularly strict.
They are. The recommendation here is a strong one. Maintain a threshold of less than 10 times 10 to the power of 3 per microliter.
A count of 10,000.
Yes. We keep that number low because randomized trials have demonstrated that prophylactically transfusing to higher counts, like 20 or 50, does not reduce the incidence of major bleeding.
But it certainly increases the exposure risk and costs.
Exactly. All risk, no benefit.
Okay, so how dramatically does that threshold change once the patient is actively hemorrhaging?
When a critically ill patient has serious active bleeding, the threshold for platelet transfusion immediately jumps. We transfuse if the count is less than 50 times 10 to the power of 9 per liter.
So below 50,000.
Yes. This is our therapeutic threshold. We're aiming to rapidly restore hemostatic capability when it's desperately needed to control a hemorrhage.
A major area of clinical change has been the role of prophylactic platelets before invasive procedures. We seem to be moving away from routine corrective transfusions for mildly low counts.
Absolutely. The evidence supports avoiding routine prophylactic platelet transfusion for many common procedures, even if the patient is moderately thrombocytopenic.
So what procedures are we talking about?
We're now advised against routine prophylaxis for placing a central venous catheter or an arterial line, for bedside thoracentesis, paracentesis, and even for routine flexible bronchoscopy without a biopsy.
So for all of those, the risk of the procedure generally doesn't outweigh the risk of the transfusion.
Exactly, unless the count is critically low.
But the consequence of a bleed in certain procedures is catastrophic, which means the threshold must be higher. The textbook example is always a lumbar puncture.
Lumbar puncture, or LP, is the key exception, and it's all because of the risk of an epidural hematoma, a truly devastating complication. This is why guidelines demand a higher threshold. Now, you noted in the critique that the numbers can look confusing in the literature.
Yes, you see references to 40 to 50 times 10 to the power of 9 per liter in one guideline, and then maybe less than 20 times 10 to the power of 3 per microliter in another. Those numbers seem contradictory on the surface.
They do, but they're actually referring to the same range, just using different units.
10
to the power of 9 per liter is exactly equivalent to 10 to the power of 3 per microliter. So when the guideline says 40 to 50 times 10 to the power of 9 per liter, that is the target range of 40 to 50,000 we aim for to minimize the risk of a spinal hematoma following an LP. The consensus is that platelets must be sufficient before any neuraxial procedure.
That clears that up. Let's revisit the central venous catheter, or CVC, placement. You mentioned that routine prophylaxis is generally suggested against, but I know a recent trial threw a wrench into that certainty, particularly for our high-risk hematology patients.
This is a great example of how the evidence is constantly evolving. A recent randomized controlled trial focused specifically on withholding prophylactic platelets before CVC placement. And this was in patients with platelet counts between 10,000 and 50,000 per microliter account range. That's traditionally considered pretty risky.
And what did that trial find?
Well, unfortunately, that trial failed to meet the threshold for non-inferiority, meaning the patients who did not receive prophylactic platelets had a higher incidence of CVC-related bleeding than those who did receive prophylaxis.
So what's the practical takeaway for clinicians? Do we just go back to routine prophylaxis for everyone?
Not entirely. The takeaway is that a blanket restriction may be unsafe in certain specific populations. For, say, a healthy patient with an acute non-malignant thrombocytopenia, withholding may be fine. But for critically ill hematology patients who often have poor intrinsic platelet function and need that CVC placement urgently, we may need a more personalized and slightly higher threshold, perhaps targeting counts below 30,000 per microliter.
Especially since they're likely to require platelet support very soon anyway for their underlying condition.
Precisely.
All right, let's move away from cellular products and into the coagulation components. Plasma and cryoprecipitate. Starting with fresh frozen plasma, or FFP, what are the definitive, appropriate indications for giving plasma?
Plasma is, in essence, a replacement for coagulation factors. So its primary indications are for active bleeding in patients with acquired severe coagulation factor deficiencies.
So you're thinking massive hemorrhage, or DIC.
Exactly. Massive hemorrhage, disseminated intravascular coagulation. It's also used for the immediate reversal of warfarin's anticoagulant effect, particularly if prosthrombotic complex concentrate, or PCC, is unavailable.
And also in PTP.
Yes, and in the emergent treatment of thrombotic thrombocytopenic purpura, or TTP, through plasma exchange.
I think the inappropriate use of plasma is just as critical to discuss as the appropriate use. What are the common pitfalls we see?
The most common inappropriate use by far is prophylactic plasma for mild coagulation abnormalities in a non-bleeding patient.
For example, transfusing plasma solely because a patient has an INR of 1.6 or 1.7 before an elective procedure.
That's the one. This practice is absolutely not supported by any evidence, and it unnecessarily exposes the patient to the risks of TACO and infection. Audits consistently confirm this gap. I saw one national audit from Australia that found, excluding massive hemorrhage, only 37% of plasma transfusions were deemed appropriate.
Only a third. That shows just how persistent this habit of correcting lab numbers is. And I understand the effectiveness of FFP for those marginal INR values is pretty questionable anyway.
It's remarkably ineffective. Post-transfusion INR corrections tend to be consistently small and clinically insignificant unless the patient's pre-transfusion INR is severely deranged.
What level are we talking?
Specifically greater than 2.5. If the INR is 1.5, giving FFP might barely nudge it while exposing the patient to all those risks.
Not a procedure.
Similarly, prophylactic FFP transfusion is generally suggested against for CVC insertion, thoracentesis, paracentesis, and even GI endoscopy, particularly in patients with portal hypertension-related bleeding where that risk of volume overload is so high.
Let's transition to cryoprecipitate. This product is specifically designed to address hypofibrinogenemia, which is often the earliest and most critical factor deficiency during major hemorrhage. What are the target fibrinogen levels we should be aiming for?
The primary indication is treating that hypofibrinogenemia, and we're aiming to keep the levels above 150 to 200 milligrams per deciliter during active bleeding. Fibrinogen is just essential for clot stability, and it drops very rapidly during severe hemorrhage or DIC.
The landscape here is changing rapidly because of fibrinogen concentrate. What's the debate between using traditional cryoprecipitate versus the newer concentrate?
This is a really fascinating area, and fibrinogen concentrate offers decisive advantages in safety, standardization, and logistics. The main issue with cryoprecipitate is its variability. It's a pooled, frozen product derived from plasma, and the fibrinogen content can range wildly. We're talking from 3 grams per liter all the way up to 30 grams per liter.
That makes accurate goal-directed dosing almost impossible.
Extremely difficult. You're basically guessing.
And concentrate solves that problem how?
Fibrinogen concentrate is manufactured to be standardized at 20 grams per liter. This allows for precise, predictable dosing. If you know you need to raise the fibrinogen by a certain amount, you can calculate the dose of concentrate needed with far greater accuracy.
Beyond standardization, what about safety and the practical logistics of a busy hospital or trauma bay?
Safety is a key advantage. Concentrate is pathogen-reduced and virally inactivated during manufacturing. This significantly reduces the risk of transfusion-transmitted infections compared to cryoprecipitate, which is a pooled blood product.
And logistically?
Logistically, concentrate is a lyophilized powder. It's stored at room temperature, and you can reconstitute it in less than a minute.
Compared to cryo?
Cryoprecipitate, conversely, has to be stored frozen, then thawed in a water bath, and often pooled from multiple donors. It leads to wasted time and resources, which is just unacceptable in an active hemorrhage scenario.
When we are rapidly replacing these factors in a massive transfusion situation, Traditional PTP, APTT, and INR tests are often too slow to guide therapy. How are we guiding real-time factor replacement today?
We are increasingly moving toward the use of viscoelastic hemostatic assays, specifically ROTEM and TEG.
Right, point-of-care testing.
Exactly. These are point-of-care devices that analyze the entire clotting process, from initiation to formation to lysis. They give us a dynamic, real-time picture of clot strength and kinetics.
So how does that differ from the traditional PTTTT test?
Traditional tests only measure the time it takes for a clot to start forming. They tell you nothing about the quality or the stability of that clot.
I see.
ROTEM or TEG gives us graphical data on the maximum amplitude of the clot, which is a direct measure of fibrinogen and platelet contribution. If that maximum amplitude is low, we know we need to prioritize fibrinogen replacement, targeting that 150 to 200 milligram per deciliter level rather than just blindly giving FFP.
It's a much more goal-directed approach.
The most goal-directed approach we have. It's the standard for modern trauma resuscitation.
That focus on speed brings us directly to massive transfusion protocols, or MTPs. This is where every minute is critical, and delay is measured directly in mortality rates.
The urgency of MTP activation cannot be overstated. We define massive transfusion as needing 10 units of RBCs in 24 hours, or, more acutely, requiring 3 units in just 1 hour.
And the critical insight here is time.
It is. Studies have quantified this risk. Any delay in activating the MTP is associated with dramatically increased mortality. Shockingly, each 1-minute delay in getting those first components is associated with a 5% increase in mortality.
Oxygen per minute.
Per minute. We have to activate the MTP immediately based on clinical signs, not wait for confirmatory lab work to come back.
Once it's activated, the protocol now mandates a balanced resuscitation strategy. The PRO-PPR trial really defined the optimal ratio of components.
The PRPPR trial was instrumental here, yes. It compared a 1:1:1 ratio of plasma, platelets, and RBCs against a 1:1:2 ratio.
And the 1.1.1 ratio won out.
It did. The trial confirmed that the aggressive 1.1.1 ratio, which essentially mimics whole blood, is safe. But more importantly, it established superiority by reducing deaths from exsanguination. The death rate from bleeding dropped from 14.6% in the less aggressive arm to 9.2% in the 1.1.1 arm.
And the goal is rapid hemostasis.
The goal is rapid hemostasis through simultaneous restoration of all necessary clotting components.
Beyond the blood products themselves, MTPs rely heavily on essential pharmaceutical adjuncts. We have to discuss tranexamic acid, or TXA.
TXA is non-negotiable in severe hemorrhage, but its efficacy is exquisitely time-sensitive.
It's an antifibrinolytic, right?
Yeah.
It stabilizes the clot.
Exactly. And it must be administered within 3 hours of injury, typically as a 1-gram IV bolus, followed by a 1-gram infusion over 8 hours. The CRA-SH2 trial demonstrated a substantial mortality benefit when TXA was given early.
But what happens if you miss that 3-hour window?
The data is stark. Giving TXA more than 3 hours after the injury may actually increase the risk of death.
Increase the risk. Why?
Because once that acute injury phase is over, the patient is often in a prothrombotic state. Adding a powerful antifibrinolytic at that stage can lock in potentially damaging thrombi, which outweighs any potential benefit. Timing is everything for TXA.
We also face the physiological consequence of rapid, large volume transfusions. Citrate toxicity. How does the MTP handle the severe hypocalcemia this causes?
This is a major and often overlooked cause of progressive coagulopathy and cardiac dysfunction during an MTP.
So the citrate is the anticoagulant in the blood back.
Correct. And when it's rapidly infused, it chelates or binds the patient's circulating calcium. You can't wait for lab results here. The change is just too fast.
So what do?
The MTPs mandate empirical calcium dosing. For instance, 1 gram of IV calcium chloride or calcium gluconate after every 4 units of transfused product, coupled with aggressive, frequent monitoring of ionized calcium levels.
Finally, a key component of modern trauma and damage control resuscitation is restricting the amount of supplemental fluid we give.
Yes. Limiting crystalloid infusions is vital. The recommendation is to limit crystalloid infusions to less than 3 liters in the first 6 hours of resuscitation.
Why is that so important?
Excessive crystalloid volume is independently associated with increased abdominal and respiratory failure, compartment syndromes, and critically, it worsens coagulopathy by diluting the clotting factors and platelets you're trying to replace.
So you're just undoing your own work.
You are. Your focus must be on maximizing the blood products, not diluting them with saline.
We've covered the indications and the protocols. Let's now turn back and dedicate some time to the risks and the system-level changes required to mitigate them. We must elaborate on the diagnosis and management of the key adverse reactions, starting with TACO, which you noted is the most common serious reaction.
TACO, transfusion-associated circulatory overload, is a hydrostatic pulmonary edema, a cardiogenic pulmonary edema. It occurs in about 1 to 5% of episodes and develops within 6 to 12 hours of the transfusion being completed.
And how do we diagnose it?
The diagnosis relies on clinical signs of volume overload, acute respiratory distress, tachycardia, and hypertension, often confirmed by findings like an elevated BNP or specific radiographic signs of cardiogenic pulmonary edema.
How do we prevent and manage TACO?
Prevention is paramount. We should reduce the infusion rate, ideally no faster than 1 unit over 4 hours, and administer diuretics before or between transfusions. This is especially true in patients with pre-existing systolic heart failure, renal disease, or other risk factors for fluid overload.
And if it occurs?
If it occurs, management involves stopping the transfusion immediately and aggressive diuresis with loop diuretics.
Now, TRLI is often confused with TACO, but it's a fundamentally different process.
Completely different. TRALI, transfusion-related acute lung injury, is a form of non-cardiogenic pulmonary edema. It happens much faster, usually within 6 hours. The mechanism is immunological. It's often mediated by donor antibodies reacting with the patient's neutrophils, which leads to capillary leak in the lungs.
Yeah.
ARDS, essentially.
And what mitigation strategies have reduced the incidence of TRALI so effectively?
The incidence has decreased dramatically because blood banks implemented system-level changes, specifically migrating toward using male-predominant plasma donors.
Why male donors?
Women, especially those who have been pregnant, are more likely to have circulating antibodies that can trigger TRALI. By using male plasma, we minimize this exposure. Management, unlike TACO, is supportive. It typically involves oxygenation and often mechanical ventilation. There's no role for diuretics.
Finally, the most feared reaction, the acute hemolytic reaction.
This is a true medical emergency. It's usually caused by ABO incompatibility, which is almost always due to human error, either during sampling, labeling, or patient identification at the bedside.
And it carries an extremely high mortality rate.
Very high, ranging from 8% up to 44%. The key is rapid recognition. The initial symptoms can be vague: a sudden fever, chills, flank or back pain, or a sudden onset of hypotension.
So if your patient starts spiking a temperature or shivering during a transfusion, what is the immediate action?
You immediately stop the transfusion. Do not pass go. Do not wait for labs. You must immediately stop the infusion, maintain IV access with saline, report the incident to the blood bank, and begin supportive care for potential shock and acute kidney injury from the hemolysis.
To combat these risks institutionally, we rely on patient blood management programs, or PBM. What does a successful PBM look like?
PBM is the comprehensive institutional framework aimed at optimizing the patient's own blood production and reducing unnecessary blood product transfusions. The Joint Commission identified transfusion as one of the top 5 overused procedures, which indicates the magnitude of the problem. A successful PBM program requires leadership buy-in and focused interventions across 3 pillars: managing anemia, minimizing blood loss, and optimizing coagulation.
And one of the most effective ways to ensure compliance with restrictive guidelines, as you alluded to earlier, is leveraging the electronic medical record, or EMR, for decision support.
EMR decision support is vital because it addresses that moment of inertia and cognitive bias. System interventions include implementing interruptive pop-up alerts, we call them best practice advisories, that are triggered whenever a clinician attempts to order an RBC unit for a patient whose hemoglobin level is 7 grams per deciliter or above.
And this forces the clinician to stop and provide a justification.
Exactly. They have to stop, provide a reason, or select an accepted bypass reason like active hemorrhage or acute symptomatic anemia.
This directly ties into making the single-unit transfusion the default order in the system.
Precisely. If the EMR automatically defaults to a single unit for stable, non-bleeding patients, it drives compliance with the restrictive strategy. The data supporting this strategy is compelling. One large healthcare system implemented single-unit default orders and restrictive threshold alerts, and they documented saving over 4,000 units of blood and $4 million in just 1 year.
But that just proves that systems-level stewardship is incredibly effective in cost-saving.
It really is.
Now, we must turn to the ethical dimension of transfusion medicine, specifically when treating patients who refuse specific blood components, such as Jehovah's Witnesses. The core principle of patient autonomy governs our approach here.
It absolutely does. When treating a competent adult patient, we must respect their refusal of specific components. They typically refuse RBCs, leukocytes, platelets, and plasma, the primary blood components.
So our ethical obligation shifts from providing standard therapy to providing medically appropriate alternatives.
Yes, while ensuring the patient is fully informed of the risks and prognosis of refusing that standard care.
So when a patient is critically anemic, let's say their hemoglobin is dangerously low, 4 or 5 grams per deciliter, and standard blood products are refused, what are the primary medical alternatives we can employ to maximize their endogenous oxygen delivery?
We have to maximize the patient's own red cell production. This involves high-dose recombinant human erythropoietin, or RUEPO, often combined with aggressive IV iron replacement. Oral absorption is often just insufficient in the critically ill.
And the goal is just to maximize the rate of red cell production by the bone marrow.
Exactly. But that takes time.
And what about those situations where the patient is critically unstable and time is a luxury they don't have?
In those truly life-threatening situations where the hemoglobin is dangerously low, perhaps less than 5 grams per deciliter, and we need immediate oxygen delivery, we may need to utilize hemoglobin-based oxygen carriers, or HBOCs.
For our listeners who may not be familiar, what exactly are HBOCs?
HBOCs are essentially synthetic, cell-free hemoglobin solutions. Because they don't have cell membranes, they don't carry the risks of incompatibility or infectious disease transmission, and they can be used regardless of blood type.
And they function by directly carrying oxygen.
Right. They can be a helpful bridge while we wait for the rich RPO to take effect. However, it's important to note they are not standard commercial products due to some historical toxicity concerns. They're typically only available in the U.S. via expanded access protocols as a last resort in extreme life-threatening anemia.
That distinction is crucial. Finally, when utilizing these alternatives or navigating a refusal of standard care, the informed consent process is even more vital than usual.
It's the absolute foundation of patient safety in this context. The physician must ensure that informed consent is robustly documented. The patient must understand the seriousness of their diagnosis, their prognosis with and without transfusion, all available treatment options, including the high-dose pharmacologic alternatives, and the specific risks and benefits associated with refusing standard therapy.
That clear, honest communication is central to high-quality, patient-centered care, regardless of the patient's specific values.
Absolutely.
This has been an extremely detailed and necessary deep dive into what is a frequent but, as we've discussed, inherently risky intervention. As we wrap up, what is the core takeaway for the practicing hospital clinician?
The central theme is, I think, non-negotiable at this point. Restrictive thresholds are the standard of care for the vast majority of hospitalized, stable adults. We should be targeting a hemoglobin of less than 7 grams per deciliter. This practice not only improves patient safety by reducing adverse events like TACO, but it also provides massive resource stewardship, all without compromising overall patient outcomes.
And remembering that transfusion is an individualized intervention.
Always. It should be driven by symptoms and context, never solely by a number on a lab sheet.
And to leave our listeners with a final provocative thought, we must always acknowledge the limitations in our evidence base, particularly in those high-stakes areas.
Absolutely. Despite the robust data supporting restrictive practices globally, we have to remain humble. In specific high-risk populations like patients with acute coronary syndromes or acute neurological disorders, the evidence remains desperately thin. And this forces us to rely on nuanced, individualized risk assessment and clinical judgment.
And that reliance really highlights a critical need for future research to bridge these knowledge gaps and provide clearer directives for the most vulnerable patients we treat.